Welcome, everyone. It is noon, so we'll go ahead and get started here, and I will hand it off to Evelyn Nelson to get us started.
Super, thanks, Christy. It's so great to see many new and returning folks on the line today. I just want to start off by introducing our presenters today. So I'll have a chance to talk a little with the group today. And we're also fortunate to have Robert Stiles, our program director for the Telehealth Rocks and Kansas Disaster Outreach Program, and our policy and outreach lead for the HTRC, and Rochelle Marding, our policy and reimbursement expert with the HTRC program. I know many of you have joined in for her presentations across the course of this series, and she's really going to take some of the clinical examples Robert and I will share and talk about with that, how does the billing and reimbursement and what considerations from a legal standpoint come into play. Before we get rolling today, I just want to remind you that the session is being recorded, so we can share that with you afterwards. Your microphones have been muted, but please do unmute if you have questions or thoughts, as well as feeling free to type those into the chat. It's also a-okay to eat lunch. We're glad to have you here with us today. We appreciate your help. I see that most folks have done this already. Please do use the three dots at the top of your Zoom window to then change your name on screen so we know who's with us today, and also so that we can send out your completion certificates. So with that, let's get rolling. We're gonna, like I say, first talk a little bit to give a context, and then Rochelle to give us some of the practicalities of the billing and reimbursement. So I'm going to talk especially about a unique adult-focused project that we have with TeleBehavioral Health. To start off, just saying, I've been in telebehavioral health for over 20 years now, and the technologies are faster, better, cheaper. So that's all great. I think what you'll hear throughout all of our presentations is that what continues to make technology work with that better technology is the reliance on relationship with families, and then also taking our very best evidence-based behavioral treatments and translating those to the technology environment. So you'll hear that message quite a bit through the presentation. Just as background, I imagine this is singing to the choir a bit, just the scope of behavioral health need in our state. This data is from 2018. If anything, some of these statistics have gotten worse through the pandemic. In 2018, Kansas ranked 32nd in the nation for access to behavioral health. Over half of Kansas adults with mental illness did not receive any type of treatment, let alone evidence-based behavioral health treatments. Because of the strong need, we're so fortunate that our primary care providers, they've really reached out to try to help meet the need. But we do find that there's gaps that often in primary care, there may be under treatment of mental health diagnoses, and just a real interest too in partnering with primary care to help match the treatment dose and strongest possible treatments to meet the mental health need. I think we're also in a fortunate time where there's more screening being done, but what we hear from our sites is, you know, we screen it, but then how do we match up to have the mental health services capacity to intervene? So telebehavioral health helps bridge that gap between high need the screening data and being able to match that up with treatment. Again, with the collaborative care project, we're really building on decades of research that shows that positive impact of integrating behavioral health into primary care, with the idea that many folks presenting in primary care will have a chronic illness that has a co-occurring mental health concern, and that by treating the mental health concern, it also opens doors to having better outcomes with the chronic disease. This is just an idea of the types of conditions and the cost implications. Just a reminder of how widespread depression is, and that with depression, you see worse outcomes and costs with folks with depression, but also folks with depression and chronic illnesses, and really seeing that impact on both the patient, the practice, and society. So that was really the context that the collaborative care model for telebehavioral health began. This is a project led by Dr. Bob Mosier, Jody Schmidt, and Janet Richardson Bars. And really the idea was with our interested rural primary care practices that are part of the Care Collaborative Accountable Care Organization, how do we match that need in those practices with telebehavioral health providers? So in this case, it's both telepsychiatry and telepsychology providers. The idea is really to address things more upstream and helping with patients' health and well-being, reducing the disease-related impact, and focusing on treatment adherence and overall management of the behavioral health and chronic health concern. So the Telebehavioral Health Network started 4 years ago with 10 practices in rural Kansas. The different part of this telebehavioral health model is it has 2 telehealth coordinators that travel to the primary care site. So they really help with some of the heavy lifting at the sites, and really make it as easy as possible for that primary care site. We all know that telehealth impacts workflow, and there are a lot of boxes to check to make sure we're following all the best practices. So the telehealth coordinator traveling to the site and helping with those components has been well received and helped with good adoption of the telebehavioral health services. What we've seen so far with that project is pretty similar to what we anticipated. A lot of telebehavioral health presentations around coping with chronic illness, depression and suicide prevention, anxiety, some pain management, less substance use disorder than we initially anticipated. And then, of course, with the pandemic, a lot of acute life events, a lot of supports around loss and grieving, and really having that opportunity to support patients and families around that. The thing that was a surprise is we're seeing a lot of patients who have pretty high acuity with their behavioral health concern and co-occurring behavioral health concerns, multiple behavioral health concerns and multiple health problems. So we're seeing them for more frequency over the telebehavioral health than we initially anticipated. I have the good fortune to share the positive impact with that model so far on the anxiety measure, the GAD-7, the depression measure, the PHQ-9, and the overall behavioral health measure, the PROMIS measure. We've seen good increases in those measures and better behavioral health functioning. The newer thing with that model is, if we've seen that success and really growing clinics, we're looking at additional roles that can help in between the behavioral health sessions. So looking at some behavioral health coaching over telehealth to continue to meet need. So with that, I'll pass the baton to Robert to talk about some of the younger age kids and some of the behavioral health models we see emerging with children.
Well, thank you, Evelyn. So KU Telehealth Rocks is sort of the overarching name for a variety of different things that we've done. It started with a program that did telebehavioral into clinics and worked with clinics, and then moved into the school setting and became Telehealth Rocks Schools. So we'll talk a little bit about the work that we've been doing, as well as a grant that we received a little over a year ago now from the Substance Abuse and Mental Health Services Administration, related to communities that had had a disaster declaration during 2019, and really focused on trauma and recovery and creation of resiliency in children in the school-based setting. Next slide, please. So when you talk about schools, I mean, one of the things that I consistently talk about just about rural communities is, especially when you're talking about a pediatric population, schools are the center, right, for families in a district. Children attend the district and are often a place where services can be obtained, or, one of the things is schools and libraries have great or better connection to fiber versus what people may have in their home, as well as other things. And in addition, schools are working on behavioral health needs, right? Those impact student success and achievement. And so schools have counselors and psychologists and special education. So really this model developed out of this idea of providing support and extending services that were needed beyond what the school had capacity to provide themselves. Next slide, please.
I'm trying to move it, Robert. It's just
Not
it's
happy,
a little
huh?
slow to respond, so I
Okay.
apologize for that.
All right. Well, you can look at the lovely picture of sort of what we think of as the 1950s sort of school nurse, and sort of how you move into the modern environment in ways that you can kind of work on those issues. So then, I don't know if we can do the slideshow, or is that, here we go. Who knows? So one of the things is, when it comes to telebehavioral health visits, right, you have to be ready and deal with whatever comes up, and especially the technology not working. So when we talk about sort of the work that we've done in Telehealth Rocks, we really focused about this idea of things being coordinated and efficient and family-centered. And also, we have this sort of cycle, like looks sort of like a plan, do, study, act. It's a cycle where things merge into each other. But we also talk a lot in pyramidal terms, in terms of sort of that tip of the pyramid of behavioral health service needs, right? Are those children that need individual therapy, need some type of individualized behavioral health service. But we really worked with these programs to also really talk about, how do we train the school staff to better be able to manage behavioral issues, and just to feel and have good competency throughout the district on the types of things that will help them work with and help children achieve. And then additionally, you have to look at the community. You have to think about, how do we create a healthy community? So in all of our work, while a lot of it ties around doing those direct telebehavioral health services, it also has a lot of trainings, and we use the echo telemetry model, which we'll get into in a minute, and really work on, how do we provide and improve capacity, not only through increasing access to providers through telebehavioral health, but also through increasing training and competencies at the local level. Next slide, please. So you can see this is more of our pyramidal model, which we adopted this for the Kansas Disaster Outreach Program, which was a SAMHSA-funded grant that focused on behavioral health needs related to recovery. And it was really interesting because we had 10 days to apply for this grant in March of 2020. COVID was just happening. They awarded the grants in August. They sped up their awarding. And it was very interesting because we were focusing on communities that had had natural disasters in 2019, but we immediately had a disaster right in front of us that was really impacting children. And so I think sometimes the uptake, but also our response often had a lot to do with COVID and helping to create, anytime you're dealing with sort of that acute event in a life, whether it's a disaster, the death of a loved one, something happening at the school, or something like COVID, you have to deal with the traumas and find ways to help deal with the behavioral health issues that result from that. So you can kind of see the model here that we do universal, we do targeted, and then of course we do those intensive interventions that tend to be one-on-one with a child or their family. Next slide, please. So as we've moved into that, and we have one more year of that funding really focused on sort of these acute traumas or incidental, I always call them kind of incident traumas, something happened that we're trying to help the child be resilient from. And a lot of our work is really focused on the idea of creating resilient children in communities. So it's not about responding to a behavior that's happened. It's about how do we lessen the impact of whether it's an act and something that happened in an environment. One thing that I say a lot about COVID is those children that have resources and strengths in their background are responding and are going to be more resilient when it comes to everything, the uncertainties, the break in school, and everything that's happened with COVID. Whereas those children that didn't have, a home environment or a community environment or resources or other other things that really lead to a more resilient or a child that can sort of deal with things and recover or, move on and continue to be successful. Those are the children that are most impacted by things like COVID. And so really working on how do we think about creating schools and communities that give every child the same opportunity, that give every child the same tools they need to be resilient. And so we decided, as we continue to develop the programs, we applied for a couple different federal grants from the Office for the Advancement of Telehealth. So one of those is to really work on this training side of things, to work on training communities and school district and really creating capacity and knowledge at the local level. And often people don't think of this sort of train the trainer or working with local providers or working with local residents to create skills and abilities in communities as telebehavioral health. But in the end, that's going to have a bigger impact than the one-on-one telebehavioral health visit that may happen with the clinical psychologist. So we're really fortunate in August to receive office funding and really looking at enhancing pediatric health and behavioral health following the COVID-19 pandemic. So use telementoring, increased training and collaboration. And one of the things that we'll be doing a lot is really working in the primary care setting and working directly with schools like we've been, also beginning to work with primary care providers. I just met with a federally qualified health center that's going to be working with us yesterday and really understanding what their needs were, not only in the medical setting for how to better manage these types of behavioral issues that come up with children, but also at the community level, how to change things in the community. And the day before that, I was meeting with one of our school districts that's working in this. And one thing that came out of that was with our telementoring and the type of training that we do, often it's school counselors and psychologists, and they're very important. When a child has a behavioral issue or things going on, they're often who's involved. But one of the things that they brought up is that their teachers are dealing with severe behaviors in the classroom without a lot of support, and that they don't really have the training that they need to work on and work with children that maybe showing severe behavioral needs in the classroom. One of the teachers described sort of an incident in a situation in her classroom with a child that often has behavioral issues as feeling like she's in an abusive relationship. But in addition, we heard that other students in the classroom are being impacted by the severe behavior that they're seeing in the classroom. These ideas of insecurity and lack of knowing what's going to happen. It may be a good day, it may be a bad day. That's really impacting and affecting the other children in the classroom. So as we look at these things, as we look at training and working in these areas, we understand that we have to get more capacity at all levels just to be able to respond and create healthy children in healthy environments. So next slide, please. So you can see these are the types of work that we'll work on, role practice facilitation, QI coaching, education, healthcare and community trainees, really enhancing the work that we're doing with Project ECHO and the telementoring model. And then also training with another grant that we have will be employing community health workers in school districts. Next slide. So you can see some of the universal community interventions that you can do during telehealth. We've done things like psychological first aid, which is in the immediate aftermath of helping community recover, helping people in figuring out what their needs are, which is not processing the trauma so much as do they need food, do they need housing, do they need to contact their loved ones, child-adult relationship enhancement, learning about how to interact with children, both parents interacting with children as well as those in the school environment and the community interacting with children, working on parent-child interaction therapy to teach those types of techniques and work through a positive model to help train parents to respond in a positive way to their child's and change behavior. Next slide, please. So we do work and have provided, and at this point are often providing 2 or 3 different echoes at a time. Many of you may be familiar with the Project Echo model, where it's a guided practice model, and really it's not, you have a didactic, but the real impact that we see and what we find from all of the surveys after our echoes is this idea of having a case, having a real world difficult example that people are dealing with, and using the experts and the other members of the echo, the other people who work in the field, to collaborate on how to best deal with the situation, or learning through that case about better ways to impact whether it's problem behaviors, suicide intention, a variety of things that we've offered echoes on. Next slide, please. So here's some of the recent ongoing echoes that we've had. You can see we could offer a problem behavior echo all year round, every year. That's such a difficult issue, and also an issue that impacts in so many different levels of people that work with children, working on resilience and self-care. And that really came out of we asked in August of 2020, we didn't know what school was going to look like, and we didn't know what schools needed, and we didn't know if they'd have the time to be in echoes and work on things. And the 2 things that school districts came back to us with were they needed problem behaviors, especially behaviors that they were seeing exacerbated by the amount of time at home and the different issues that developed out of COVID. And the second thing was that resilience and self-care, this idea that teachers themselves needed to learn some of these techniques, not only for their own self-care and their own health, but also to work with children on becoming more resilient in these areas. And then, really moving into lots of other things. We do some medical echoes like food allergy. We have a very successful echo looking at children with very complex medical conditions. And just yesterday held almost 100 people attended a webinar where they worked on their own resilience plan, their own self-care plan. So a lot of work in that area, and we're very fortunate to have funds to really expand on that and continue that telemetry type work. Next slide, please. So Telehealth Rocks Communities is the other grant that we received in August of 2021, and that's really focused on evidence-based universal. And I talk about this as sort of the background trauma, right? Social determinants of health, those impacts, those things in an environment that impact a child's success and sort of expose them to this background level of continuing trauma and create trauma in their lives. And so we're really excited to bring the role of community health workers into the school setting. I used to work in Missouri with a federally qualified health center there, and we had therapists in schools alongside community health workers because we absolutely want to provide the behavioral health services that are needed as to every child that needs them. But we've got to get at quit causing those things, to quit help change the environment and help change circumstances so that we have less children in need of services. I used to say in school districts that I knew we'd be successful when we needed less therapists, because we were dealing with children's issues, we were getting them on the right path, we were intervening when we had to, but it was, kids weren't at that supreme level. They weren't at that extreme level of need because they hadn't gone without resources and inputs, as well as, my goal is always to get a kid in, work with them as soon as an issue starts to develop, not allow it to become a major issue. We don't want kids to get diagnoses. We don't want them to have a diagnosis because something's exacerbated to that point. And then, so really using community health workers to link parents and families to resources that they need, whether that's healthcare or social services, food, housing, those types of things. So really excited about that work. Next slide, please. So you can see these are the types of work that we'll do. So we'll look at patient-driven care. We're moving into a consumer-directed telebehavioral health program, which is very interesting when you think about schools and parents really being able to reach out and also being able to contact and work with the community health worker to identify the needs that they have. And then, of course, moving into working with schools and the community health workers, which then lead into the behavioral health services. Next slide, please. So I wanted to bring up this other thing because time and time again in every conversation I have, I find that emergency preparedness, dealing with an emergency, whether it's the police, the fire department, EMS, adults that are having some type of behavioral need, behavioral health emergency, are difficult to work, to come up with resources for, to manage in rural areas. But it's especially difficult for children, right? There are very few resources. There are very few inpatient facilities. Often EMS in the field is having to deal, and they're not as trained and don't have as much knowledge or ability when it comes to meeting needs or managing a behavioral health emergency. So we worked alongside the Kansas Department of Health and Environmental and Children's Mercy, began work about a year ago now on a collaborative related to EMS for children. And the collaborative continues. It just had its first sort of overarching meeting for the next year and beginning work on coming up with a plan and developing resources across the state related to EMS management of children in behavioral health emergencies. So you can see the goals for that are to enhance access to emergency care and to assess, develop, and disseminate best practices, right? So these are things where there can be a linkage to telebehavioral health at a distance by EMS in the home or in the environment where the emergency is happening. So really excited about the work there and beginning to develop some models to deal with that type of situation, especially in very rural areas with limited resources when it comes to children's behavioral health. Next slide, please. So these are just some of the things that we think about that we hear a lot. Suicide, psychiatry, drug management for children, right? This is not something dealt with, difficult to deal with in the primary care setting. Need for psychology and therapy, other types of visits like autism diagnosis or behavioral analysis, developmental pediatrics, toileting and feeding issues. So those are some of the questions or things that have come up as we think about the need for pediatric telebehavioral in rural communities especially. I think that's the last slide, right? It is. So happy now. Hope you found some of that interesting, but to kind of hand over to Rochelle and she can talk about the nuts and bolts of how some of these types of programs work.
All right. Let me see if I can share my screen there. All right, thumbs up, that's a good sign. So Evelyn and Robert said a couple of things that I'm going to try to incorporate in some of the coding and the billing, right? How you get reimbursed for these telebehavioral health services, whether it's for adults or children. When you're providing the services, it would be great to have some compensation for that. And a couple of themes that they mentioned that I want to make sure I'm covering as I'm walking through this are prevention and integration with primary care and schools and children. So as I talk about some of these, I'm going to mention those topics as well and how that's incorporated into the coding and billing pieces. So before I even get started into some Medicare services called behavioral health integration, and one that's sort of a step up from behavioral health integration called psychiatric collaborative care, both of which are services and programs that are integrating behavioral health concepts and folks with specialized training in behavioral health into the primary care setting. But before I talk about those, I want to make sure I touch on a couple of things that I jotted down while Evelyn and Robert were talking. And one of those on the prevention piece that both of you mentioned is there's a depression screening service, and it's a service that Medicare pays for and has paid for a number of years. And I'll just mention the code briefly, G0444. And it's up to 15 minutes annual depression screening for individuals who have Medicare. And the great thing about that code is that it can be reported in conjunction with office visit codes like evaluation and management services. It could even be performed in conjunction with an annual wellness visit that you're doing for an individual with Medicare, or a subsequent annual wellness visit, or the IPPE, sometimes called the Welcome to Medicare visit, where you're collecting the patient's providers and doing a comprehensive health plan and screening program for the patient. It's pretty simple too. To report the depression screening service for Medicare, they want you to use a recognized, validated screening tool. That could be something sometimes as brief as a PHQ-2. Depending on the results of that, you might expand to a PHQ-9. They don't determine which screening tool you use or method you use. It can be something that the patient completes. It could be something that the nurse is completing with the patient. And then based on the results, the provider may review that and refer to community resources, to maybe psychology or psychiatry professionals, or maybe begin the patient in these behavioral health integration or psychiatric collaborative care programs if more assistance is needed. But that's an annual screening benefit for individuals in the Medicare program. If you're already doing it as part of your kind of annual visits with patients, you can look into that code and look into the documentation requirements, report it, and get paid for that screening that you're doing. I want to talk about too, as I'm going through this in just a little bit, the crisis intervention. Robert, you mentioned the EMS with children. In the next couple of days, I actually anticipate today, tomorrow, maybe Monday, when the Medicare fee schedule for 2022 comes out, one of the questions or considerations that Medicare was proposing revolved around crisis intervention as a telehealth service and as an audio only service, and whether and to what extent and for how long that would continue to be allowed. I worked with one of the professional associations in preparing comments back to CMS from the proposed rule, and provided some resources on supporting continuing to allow a crisis intervention type service as telehealth, and even more specifically as audio only, because there's really good literature about suicide hotlines and crisis hotlines as the first line of defense in a crisis. So that's something to be looking for in the next couple of days when that comes out. We have a session coming up in November that will go over that final rule. So more information on that to come when that final rule comes out. So I want to talk about, actually, again, before I get started on these two, I've talked a little bit about a service that's already available under the Medicare program for telehealth to be covered in situations that it would not normally be covered under the Support Act, which allowed telehealth to be covered for substance use disorders and mental health conditions co-occurring with substance use disorders. And when I say that these services would not ordinarily be covered, if you ignore the PHE, where we've got all of these flexibilities to allow us to render care to patients at home and outside of rural areas, even before the PHE did that, these telehealth visits for patients with substance use disorder or mental health conditions co-occurring with substance use disorder were covered for patients at home and outside of rural areas. And that's a permanent change. So even when the PHE is gone, knock on wood, hopefully soon, that's still going to be available. Then there was something called the CARES Act the Consolidated Appropriations Act that expanded that coverage, again, ignoring the flexibilities of the public health emergency, to allow telehealth to be provided for mental and behavioral health services to patients at home who are not necessarily in a rural geographic area as would normally be required for Medicare. And that will continue even after the public health emergency ends. That's also assuming we don't have legislation in the meantime that would make home a permanent originating site for individuals for Medicare coverage, or that would permanently remove the rural geographic area restriction, because we have a lot of federal legislation, a lot of different bills that are targeting those two areas in particular, even outside of the mental and behavioral health telehealth context. So I wanted to mention those two as well, but the behavioral health integration and psychiatric collaborative care in particular, I wanted to talk about because Evelyn's emphasis on the integration of behavioral health in the primary care setting. And that's exactly what these benefits do for individuals with Medicare. As we'll talk about in just a little bit, the downside right now is, from what I can tell, the Kansas, Missouri, and Oklahoma Medicaid programs do not have fee schedule rates for these services. So these are Medicare benefits that they're relatively new. And so it may take a few years for the state Medicaid agencies to review the services and to add them as compensable, reimbursable benefits. But I want to walk through what they are. So for those individuals with Medicare, you can kind of see what the program looks like. They're modeled very similarly to chronic care management, if you're familiar with that, the program and that benefit under Medicare, with a mental behavioral health focus. So the idea behind these is we've got kind of a team approach that's focused on the patient's mental or behavioral health conditions, integrating with primary care. So it's collaborative. It focuses on integrated treatment, meaning we're kind of looking at the whole person for these behavioral health integrations. So I think of behavioral health integration and the next service that I'll talk about, psychiatric collaborative care, as sort of a step up. So we have behavioral health integration first and psychiatric collaborative care as a little bit more intensive model of behavioral health integration. So BHI, behavioral health integration, we have several members of the collaborative care team that are helping with these services for the patient. We have the treating practitioner. So this may be the primary care provider, family medicine, internal medicine, et cetera. They're kind of the hub, so to speak, for these services. Certified nurse midwife is among those, but we have a physician or physician assistant, nurse practitioner, clinical nurse specialist. They're typically primary care, but they don't have to be. Medicare gives examples of where behavioral health integration may be appropriate actually with specialty care, folks with oncology, even psychiatry, cardiology. I think oncology is a really good example of a specialty or a discipline where behavioral health, mental health interplays very much with the patient's medical condition that specialty is monitoring and responsible for. We, of course, have the patient, and the patient's part of the care team in this program. They're involved in the care plan, and they're involved in the interventions and the check-ins with the patient. And then there's clinical staff. So we have the billing practitioner, which is typically up here, the treating practitioner, often primary care, kind of the hub of these services. And we can have contractors, we can have someone in-house who's a nurse or kind of a clinical discipline. The term clinical staff has a little bit of a specialized meaning. It's generally referring to what we would consider probably a CNA, a CMA, an LPN, an RN, but typically is not a clinical person who would bill for services on their own, more of support and ancillary staff in the practice. So looking at what the behavioral health integration does, or what the benefit is, we have an initial assessment by a member of the primary care team. So that's usually the primary care provider, right? We've got some kind of validated rating scale that's used as an assessment for the patient and their behavioral mental health condition. And as I'm saying that out loud, it takes me back to the title of these services as behavioral health integration. If we come down to the bottom, it's really not, that's almost a misnomer, because it's not focused on behavioral issues specifically. It could be any mental, behavioral, or psychiatric condition, not just those that manifest as behavioral issues. We have care planning by that primary care team member, often a primary care specialty, but it doesn't have to be. And then we're coordinating the patient's behavioral health care with other providers. And so again, it's not limited to behavioral health providers. It's not limited to psychiatry. And in fact, often is initiated in the primary care setting and not by specialists. So we've got then, if we look at I've got the code here that can be reported to Medicare. So it is behavioral health, mental or behavioral health care management services Again, not limited just to behavioral health diagnosis, any mental, behavioral, psychiatric diagnosis, at least 20 minutes of clinical staff time. So again, that clinical staff, those are folks with clinical credentials. They don't have to be a nurse practitioner, a physician assistant, or a physician. Those can be nursing staff completing that time. These services are directed by the billing practitioner, often going to be someone in primary care, but it doesn't have to be. And it's 20 minutes in a calendar month. So not a running 30-day period, but January, February, March, etc. And once we meet that 20 minutes of clinical staff time to complete these activities, we could bill Medicare for the patient's behavioral health integration. So we've got that initial assessment, the validated rating scales, planning specific to the patient's mental or behavioral or psychiatric conditions. And so it's not necessarily the comprehensive care plan that we would see for chronic care management. This has a mental and behavioral health focus. If this is a subsequent visit, that might be a revision of the care plan for patients who are not progressing or whose status has changed, whether that's improvement or whether that's lack of improvement or even worsening or exacerbation. We have the coordinating treatment with other members. That could be psychotherapy, that could be psychology, psychiatry, counselors, that could be schools. So facilitating that coordination, continuity of care with a member of the designated team. So that's kind of the integrative approach that's taken. And a lot of that work can be done by the clinical staff in a calendar month. I should mention too that the supervision of this. So because it's being done by clinical staff, right? We don't report these services under the name of the nurse or the LPN. They're getting reported under the name of the billing practitioner, the primary care provider, the oncologist. So they're done incident to that initial provider's plan of care. And the clinical staff person's work to do all of this integration and care coordination, that can be done under general supervision. So general supervision has a really specific definition under Medicare, meaning the provider, that primary care physician or the oncologist, they don't have to be in the same physical location as the clinical staff person. They don't have to be in the room when the services are provided. They're just overall responsible for the care that's being provided to the patient. In an environment like COVID and afterwards, that's a really great benefit to be able to have this as general supervision, because it means we could contract this out to a company that specializes in the clinical staff component of the behavioral health integration. Or it means that clinical person, they could be working remotely. They could be working from home to monitor our patients with behavioral health conditions and work on this integration kind of as the focus and the work that they're doing. So sort of a step up from behavioral health integration is psychiatric collaborative care. You'll see this abbreviated COCM. I don't know why they chose that abbreviation for psychiatric collaborative care, but you'll see CCM for chronic care management, that separate benefit under Medicare that could be for medical diagnoses, diabetes or hypertension or congestive heart failure, asthma, et cetera. This is very similar to that approach with a psychiatric mental behavioral health focus. So this care team looks a little bit different because you're going to see two pieces of this that were not in the behavioral health integration model. So this is the reason that I call it kind of a step up, because we have someone that's a psychiatric consultant, someone that's trained in psychiatry and qualified to prescribe the full range of medication. So typically that would be a psychiatrist who's specifically helping with the psych med component of this patient's care and has the training and the emphasis and the expertise on the medication management piece for that patient. Then we have someone that's called the behavioral health manager. That's not necessarily a job title. That's more of a function in this model. That's someone who's got training in behavioral health. It could be a nurse, it could be psychology, it could be social work, but they've got some specialized training. They're under the direction of the billing practitioner, so that may be our primary care provider, very much like the clinical staff person is under the direction of the treating or billing provider under the behavioral health integration model. So this looks fairly similar to behavioral health integration in that we have this initial assessment. We've got the validated rating scales, we have care planning, but then we get into a little bit more complex, more time intensive and specialized services with psychiatric collaborative care. We have that behavioral health manager, who, again, that doesn't have to be their job title. It's more of a function that can be a nurse, it can be social work, it can be psychology, that is doing some proactive outreach with the patient. So Robert, this is kind of that prevention piece. Like, our success in these programs are when we don't have to do them anymore. We've got the conditions well managed. So proactive, systematic follow-up with the patient. We're using validating rating scales and kind of a registry to keep track of our patients and follow up with them. How are you doing taking your medications? Are you tolerating them? Are you having any adverse side effects that are troubling you? And they can coordinate back with the psychiatric consultant on any issues with the patient's meds, any of those side effects, any failure to adhere to the plan that the treating provider may need to know about. So this is that regular ongoing follow-up, the check-ins in between face-to-face visits with the patients that can be really critical. We're regularly reviewing the caseload with the psychiatric consultant and going through the patients, going through their meds. How are the patients doing? Are they following the treatment plan? Are they having side effects? Do any adjustments need to be made? And all of that is being then reported back to, if I go back to this model, we still have the treating the primary care provider as kind of the hub for these services that's responsible for the overall care and management of the patient. These codes are relatively new benefits under the Medicare program, and they've been evolving a little bit. So we have a code for the initial or subsequent psychiatric collaborative care that was created because the other codes for the first 70 minutes and for the first 60 minutes, that's quite a bit of time in a calendar month. And so this G2214 was created to capture work on psychiatric collaborative care that may be less intensive than the 70 minutes or 60-minute timeframes that we had previously. And that code can be used for that initial calendar month or for subsequent months. You may see that one when you have an individual who could benefit from psychiatric collaborative care, integrating with primary care, and someone who's monitoring the psychiatric and behavioral mental health medication specifically, but who is fairly well controlled or not a particularly complex case. But then the other options, 99492, 493, this is for an initial month. So only once per episode that we're have the patient in this program for the first 70 minutes. That you may see, that's the work to do that initial assessment, to develop the care plan, to get the patient kind of enrolled in this program and all set up. And it's more of a comprehensive assessment in that first calendar month that we would only report once per patient in an episode. Then for each month after, for the first 60 minutes of care and activities for psychiatric collaborative care, then we could report 99493 each calendar month afterwards that we meet that 60-minute threshold. And for patients who may be even more complex or have a crisis or an exacerbation in a particular month, this add-on code was created to capture additional increments of time in a calendar month when more time was expended on a particular patient for their psychiatric collaborative care. So I'll go through that's the good news. We've got some expanded benefits that are integrating behavioral health and folks with particular expertise in those areas with primary care. And those are reported in addition to your in-person, face-to-face evaluation visits or to other telehealth visits that you're providing for the patient. The bad news or the downside is that the Medicaid programs don't yet have fee schedule rates for the behavioral health integration and psychiatric collaborative care yet. However, all three of the states, Kansas, Missouri, and Oklahoma, do have some other kind of benefits and perks to their behavioral telehealth services and benefits that are not available under the Medicare program. So this is focused on Kansas initially. So Kansas has some specific benefits for autism-related services. And Robert, you mentioned that. And one of the benefits that has been added during the public health emergency is allowing these to be provided to individuals who are at home. I thought that was a really important expansion of the ABA related services for children who may have autism diagnoses and treatment that's being provided, especially when I was listening to you talk about March of last year and everything that happened, and schools closing was one of the things that happened. And that's one of the places where some children may be receiving ABA and autism related services in the school. And when there is no school to go to receive those services, home was the natural next location where many of those services were provided. So when that's being provided to individuals who are at home in the state of Kansas under the Medicaid program, you would select the CPT code describing those services and use place of service 02, not home, which I think is 12. This particular bulletin still wanted you to use place of service 2, which is a telehealth service. Now, when the client, when the patient is at home, or even at school for that matter, receiving this service via telehealth, then there's no originating site fee, the Q3014, unless there's actually a person at home or in the school with the patient, kind of helping facilitate the services along with the distant site provider who is rendering the ABA or other autism related services. Still talking about Kansas Medicaid, this is one of the examples of crisis intervention, and I mentioned under the Medicare program. I'm going to be watching in the next couple of days for the final rule to see what Medicare's kind of permanent or semi-permanent policy is with respect to crisis intervention as well. But these have been added to the telehealth list under the Kansas Medicaid program to be delivered via telehealth, including audio only, which is exactly what we're wanting to see happen on a permanent basis under the Medicare program during the public health emergency. Now, the Kansas Medicaid bulletins that incrementally added services and added flexibilities during the public health emergency went into effect for the most part in March of 2020. And there's been language added to those bulletins that says they're effective until withdrawn. So they don't necessarily get withdrawn automatically when the federal public health emergency ends. And if you'll remember, in Kansas, the state emergency declaration expired or was withdrawn earlier this year. So it has already been removed in the state, and these telehealth policies have not been withdrawn or revoked yet. So that will be something we'll want to keep an eye on, and whether these crisis intervention services will continue to be permitted via telehealth, and even better as audio only telehealth services, even when the federal public health emergency winds down. A few others. So I've added the list. This is a comprehensive list of services that are covered under KMAP on an ordinary basis, even outside of the public health emergency via telehealth. I've got the link here when the slides go out after the session, and you'll see quite a few of these are the psychotherapy add-on codes, evaluation management services, the initial diagnostic exam. So there are quite a few quite a large portion of these are mental behavioral health service focused in the Kansas Medicaid program. Now, switching gears to Missouri Health Net, unfortunately, the Medicare Behavioral Health Integration and psychiatric collaborative care models that are paid for under Medicare are not yet on the Missouri Health Net fee schedule for Missouri Medicaid. We don't have a lot of data on those yet under the Medicare program, and maybe as more data becomes available and is published on cost benefit we may see those added to the state Medicaid fee schedules as well. But one good benefit under the Missouri Health Net program, it's very clear, kind of, it's actually written into the statutes and regulations that these can be provided to patients clients who are in school. When they're in school, the place of service that we report is a little bit different than in Kansas. So if you're a provider that's crossing state lines, you've got different rules depending on which state Medicaid agency you're reporting the claim to. And in Missouri, you would use place of service 3, which is a school location. And to indicate that that's a telehealth service, you do that with a modifier GT, instead of using what Kansas uses place of service 02 for these telehealth services. One thing to keep in mind that Missouri Health Net is clear about, though, while they do cover the mental and behavioral health services to the same extent that they do a face-to-face in-person visit, that also means that any pre-certification or pre-authorization requirements that apply to the in-person face-to-face service also apply to those services when rendered via telehealth. I captured this from a slide that was published just a few months ago by Missouri Health Net, and I think this is fascinating. So the distance site provider, the professionals that are rendering telehealth, look at the evolution of telehealth in the state of Missouri for Missouri Medicaid, right? So we're getting to the end of 2019, we had about $1.5 million in telehealth services. And then this was kind of the beginning. Look at that jump from 1 million to over 9 million in just one quarter. And then after the public health emergency, really hit hard in the month of March, look from April to June, almost $14 million, up from 1.5, just 6 months prior. So clearly there is a huge need and benefit and usage of telebehavioral health services in the state Medicaid program. I wouldn't be surprised if Kansas and Oklahoma had similar metrics. But what I think that means we'll see, given their extraordinary use and expansion, are probably policies that are going to continue a lot of what were initially created as temporary coverage policies extended on a permanent basis. So for the state of Oklahoma, I've got a couple of links here. Oklahoma actually does have behavioral health integration on its as a benefit. When I click on this link, and I'll have it on the link for you all, there's a policy outlining kind of the coverage and the restrictions, but allowing 99484, the Medicare Behavioral Health Integration benefit. I guess it's not actually Medicare, a Medicare code. It's in the CPT book, but it is a benefit that Medicare recently covered under the Oklahoma Medicaid benefit as well. It also clarifies that the behavioral health integration services, they're designed to not necessarily be 20 minutes, 60 minutes of face-to-face time. They're typically kind of behind the scenes work for managing the patient's behavioral or mental health conditions, but those services can be done remotely. They can be done via telehealth. They can also be done by remote patient monitoring, which is a really interesting clarification in Oklahoma that we don't have under Medicare or Kansas Medicaid or Missouri Medicaid. And when the Medicare final rule comes out here in the next few days, remember that there's a new category of services called remote therapeutic monitoring. RPM, that's monitoring biologic, physiologic data like your heart rate, your blood pressure, but RTM is going to be more subjective, self-entered data. So that could be like a daily PHQ-2. How are you doing? How are you doing today? How's your mood today? Or ranking the patients. Did you take your medicine today? All of those things that could be part of remote therapeutic monitoring, as well as tie in very nicely to the behavioral health integration services. Oklahoma Medicaid has policies that cover remote patient monitoring. They're a little bit ahead of Kansas and Missouri Medicaid that aren't as clear on their coverage of those remote monitoring services yet. And then also when I send this link out, you'll be able to see the fee schedule, the actual payment rates in Oklahoma for services that are specific to mental and behavioral health, and tie those back to the full list of services that are covered right now via telemedicine under the Oklahoma Medicaid program. So with that, I think I have a whole 30 seconds to spare. I'll pause and see if there are any questions for Evelyn or for Robert or myself.